is Dr. Zablip Santhraj. He is the past president of Sri Lanka College of Cardiology, and he's a consultant cardiologist now working at the Navaloko Hospital group of hospitals in Colombo, Sri Lanka. And he's going to talk to us on managing systemic hypertension in special populations. Over to you, Dr. Santhraj.
First, let me thank the Sri Lanka College of Cardiology and the European Society of Cardiology for inviting me to give this lecture. And I'll straight away go to the first topic, that is hypertension in pregnancy. It is a very important population in management of hypertension. In pregnancy, first you have to diagnose whether they have hypertension, and it should be repeated and confirmed. And also you have to find whether they are in the high risk group, like their blood pressure is, if the blood pressure is more than 140/90, you can diagnose hypertension with a repeated measurement. And if the blood pressure is more than 160/110, then you diagnose severe hypertension in pregnancy. And these are the patients should be promptly treated, and you should consider it's an emergency. And you have to re-stratify these patients, measuring their protein in the urine. So if there is proteinuria, then of course they fall into a high risk group, and they are at a high risk of getting preeclampsia. So you can measure proteinuria by different methods that is tabulated in this slide. So one of those will be a valid method of measuring protein. Now, if the blood pressure is more than 140/90, if it is diagnosed in less than 20 weeks of gestation, you diagnose chronic pre-pregnancy hypertension. But these mothers are more prone to develop preeclampsia. You have to keep it in mind. If it is diagnosed more than 20 weeks, then it's called, then you have to check whether there is a target organ involvement. If there is no target organ involvement, it is gestational hypertension. If there is target organ involvement, then of course you can diagnose preeclampsia. What are these target organ involvements? It can be proteinuria, other maternal organ dysfunction, or uteroplacental dysfunction. Other maternal organ dysfunction may be acute kidney injury, liver involvement, you can measure it by increased aminotransferase, or neurological complications like altered mental status, blindness, stroke, or clonus, persistent visual scotoma, or hematological manifestation like thrombocytopenia. If you come across one of these, then of course you have to diagnose, you can diagnose preeclampsia. The prevention of hypertension disorders in pregnancy, the aspirin constitute one of the most important treatment. Who are the patients, who are the mothers should be prescribed aspirin? The prophylactic use of aspirin, use lower dose aspirin for men with one or more of the major risk factors, that is prior preeclampsia, chronic hypertension, pregestational diabetes mellitus, or maternal body weight more than 30 BMI, or chronic kidney disease or antiphospholipid syndrome. There are minor risk factors like advanced maternal age, family history of preeclampsia, short duration of sexual relationship before the pregnancy, and prematurity. The treatment goals in pregnancy, you should bring down the blood pressure less than 140/90 according to the ESH guidelines. The NICE guidelines say the targeted blood pressure is 135/85. The American Diabetic Association, of course, with pregnant patients with diabetes, the blood pressure should be reduced to 135/110, and the DASLE below 85. So the management of hypertension in pregnancy involved, first you have to diagnose. If it is less than 140/90, normal blood pressure, reassure and review in the next visit. If it is just, you have to check how bad it is. That is, if it is 160 or 110, severe hypertension in pregnancy, it's an obstetric emergency. So you have to initiate pharmacotherapy, and also it's a reason for admission of mothers to the hospital. If it is not, then you can start single antihypertensive agent to reduce the blood pressure to target 140, below 140/90. If the diastolic pressure is more than 85, increase the antihypertensive medications to reduce to that level. If it is less than 85, you can continue the same treatment. The medication wise, the rule is you have to use a medication which has been used in used in hypertension for a long period of time, that is time-tested medications. Those are labetalol, methyl-dopa, long-acting oral nifedipine, and other beta blockers like acebutolol, metoprolol, pindolol, and propranolol. All these medicines have been in the market for a very long period of time, and they have not been shown to cause any fetal or maternal problems in most of the patients. The second line of drug, if you can't control the blood pressure, you can use clonidine, hydralazine, and thiazide diuretics. ACE inhibitors and ARB blockers are contraindications because they can cause fetotoxicity and the renal system. So what the guideline says, the low dose aspirin should be recommended in women at high or moderate risk of preeclampsia from week 12 to up to the week 36 to 37. In women with gestational hypertension or pre-existing hypertension superimposed by gestational hypertension or with the hypertension and subclinical organ damage or symptom, initiation of drug treatment is recommended over the blood pressure of 140/90. In all other cases, initiation of drug treatment is recommended over 150/95. Systolic blood pressure more than 170 over diastolic blood pressure 110. In pregnant women, it's an emergency and hospitalization is recommended. Methyl-dopa, labetalol, and calcium antagonists are recommended for the treatment of hypertension in pregnancy. Again, these all are class 1 indications. The women with gestational hypertension or mild preeclampsia, delivery is recommended in 37 weeks. It is recommended to expedite the delivery in preeclampsia and adverse conditions such as visual disturbances and hemostatic disorders. The preeclampsia associated with pulmonary edema, you have to treat the hypertension with IV nitroglycerin, and severe hypertension, drug treatment with intravenous labetalol, oral methyl-dopa, nifedipine are recommended. These are all again class 1 recommendation. You have to reduce the weight gain in the pregnant women with hypertension. The ACE inhibitors and ARB blockers are a contraindication. A little bit about management of patients with diabetes. Hypertension and diabetes are coexisting illnesses. And diabetes patients are more than twice likely to have hypertension than the normal population. And they also have mostly isolated systolic hypertension. They have enhanced variability of blood pressure. They are more prone to get orthostatic hypertension because the neuropathy. And they experience less reduction in the nocturnal blood pressure, non-dippers. The blood pressure control in these patients present great challenge. And because the target blood pressure is quite low in diabetes, the response to treatment is often poor. And also, diabetes and hypertension involves certain common risk factors like insulin resistance, dyslipidemia, obesity, and gene problem. and it can lead to atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial glomerular. All these can lead to cardiovascular problems. So the treatment goals for the diabetes is the American Diabetic Association. If the target is less than 130/80, and if they have atherosclerotic cardiovascular disease, the target should be less than 140/90. So the guidelines, EHS guidelines says the antihypertensive drug treatment is recommended for people with diabetes when the office blood pressure is more than 140/90. Target, as I mentioned, it should be reduced to 130 but not below 120 systolic. In older people, the target is 140 to 130 systolic, and diastolic is always less than 180. I'll just skip these slides because in the interest of time. And the recommended treatment for confirmed hypertension of people with diabetes. Now, you have to, if the initial blood pressure is 140/90 and below 160/100, maybe you can try to manage with a single agent. But if they have albuminuria, your preferred agents will be an ACE inhibitor or ARB blocker. If it is not, you can use any guideline recommended first line medications. If the initial blood pressure is more than 100, you are better to start with always two agents. If they have albuminuria, it's better to start with ACE inhibitors and ARB blockers with a calcium channel blocker or a diuretic. And if there is no albuminuria, then you can choose any medications and combine them. If the treatment is tolerated, continue the treatment. If the treatment is not at target, you can add medication from the other group of medications. If they have adverse effects, like if they have cough or ACE inhibitors, then of course you can change the ACE inhibitors to ARB blockers. And in the prevention of diabetes, it's very important in the potential patients who can develop future diabetes. It is reasonable to use ARB blockers and ACE inhibitors because the studies have shown that when you use these agents, the new onset diabetes is prevented. So patients who have family history of diabetes and those who are more prone to get diabetes, when they present with hypertension, it's better to use these agents to prevention of diabetes. And again, the new SGLT2 inhibitors has favorable effect on the blood pressure. So these agents should be used in control of blood sugar because it has favorable effect on blood pressure. It's better to use these agents whenever it's available. I will go through some other groups of patients. It's a chronic kidney disease patient. As you all know, it is ACE inhibitors and ARB blockers are the first line medication in chronic kidney disease. And whenever you start the ACE inhibitors and ARB blockers in this patient, you can actually allow 30% increase in the serum creatinine because it's happened with the ACE inhibitor ARB blocker treatment. If that happens, it's okay. But if it is more than 30%, then of course you have to investigate this patient for some other conditions like bilateral renal artery stenosis. And of course, depending on the requirement, you can use beta blockers and other medication as it is required. The coronary artery disease, of course, the first line medication, the ACE inhibitors, ARB blockers, or beta blockers with calcium channel blockers are recommended, and the combination can be adjusted accordingly. The patients with heart failure, ACE inhibitor, ARB blockers, and diuretics are the first line medication with beta blockers. And again, you can combine this medication according to their needs. When the patient has atrial fibrillation, the heart rate control become one of the important aspects. So you can use either beta blockers and non-hydropyridine calcium channel blockers as to control the heart rate, plus ACE inhibitors, so ARB blockers to control the hypertension. Thank you.
Santraj for that very elaborative lecture, and we have some more time for questions. May I invite the audience for some questions?
Can you hear me?
Yeah, yes, we can hear you.
Yes, I mean, what we have just heard in the last two talks is, the everyday issues of the hypertension treatment that we need to do so often. And especially also the very nice lecture where we heard about the blood pressure monitoring and how to measure and how to evaluate. I would like to ask Brian, you do all of these, you work with all of these patients who have hypertension. How do you approach the measurement? In your outpatient clinic, patient shows up, you want to diagnose hypertension. What do you rely on currently? And also your thoughts about the future, where we heard these interesting things about, smartwatches or other devices that might help us in the future to monitor and detect blood pressure.
So first thing to say is I never measure the blood pressure myself in clinic because I don't think it gives a very reliable reading. Patients are often in a very unusual environment. They're meeting the senior doctor. It's just atypical. So I mostly rely on 24-hour blood pressure measurement to get a first impression of what patient's blood pressure really is. Or many of the patients in this country now, particularly during the pandemic, have been measuring their own blood pressures at home. And if they're doing home readings, I ask them to bring the monitor in and get one of the nurses to check that they know how to use it and that they're doing it properly. And if I'm confident that they're measuring blood pressure properly with their own monitor, I would much rather rely on home readings than anything measured in the clinic. So I guess my message is that I'm moving more towards out-of-office blood pressure measurement, either through me organizing an ABPM or the patient bringing, reliable records from home that I can use to both diagnose and make adjustments to treatment. I think if that's not feasible, it's always useful to see how well the office blood pressure corresponds to a single ambulatory reading or a home reading, just to make sure that there's not significant white coat effect in the office, which may cause you to overmeasure and over-treat. So I think they're the main principles. But I think there's a shift, and I'd be interested from our colleagues in Sri Lanka whether there's accessibility to ambulatory monitoring or indeed whether there's been more home measurement being used. Particularly during the pandemic, we've actually encouraged it because people haven't been able to come up to the hospital to have their routine visits.
Professor Brian, I think we have another problem in our setup. Some of our colleagues follow the ACC guidelines on the management of patients, and some of our colleagues go with the ESC guidelines. Now, as you have correctly mentioned, the SPRINT trial and the STEP Chinese trial, there is a benefit of reducing cardiovascular morbidity and mortality with a considerable number of patients with intensive blood pressure lowering. And how would you recommend for our population or our colleagues to set up a new guideline on combination of these two, or to go into some sort of different method to get the patients being unconfused, because the patients can sometimes be on a lower blood pressure and another colleague might reduce the blood pressure pills to increase the blood pressure of the patient, and depending on the way that the colleagues have been treating. And how would you advise us to follow this?
So I've had a lot of debates and discussions with Paul Welton, who's a good friend in the US, who led the US guideline at the time I led the European one. Look, I mean, I know what they were trying to achieve in the US. They thought that by having a more aggressive threshold and target, they would get more people treated and they would get, on average, a lower blood pressure in the population. But I think lowering the threshold to 130 and saying everybody's hypertensive if their systolic's above 130 really created a massive extra number of people who might be medicalized and treated. And I don't think that would be popular across the rest of the world. And nor do I think it's justified, actually. And secondly, I think trying to treat everybody to get below 130 is just not going to be possible in everybody. So I think our targets in Europe that, we define hypertension as a blood pressure above 140 because that's the level of pressure at which we know that drug treatment is beneficial. We don't know that for everybody with a blood pressure above 130. So that's why we use that threshold. And we recommend getting below 140 because we know from the evidence that that is beneficial in the majority of people. And we recommended going down to 130 or lower if you will tolerate it. So there aren't huge differences between Europe and the United States. I think the main difference is that them recommending 130, less than 130 in everybody, and us saying get down below 140 in everybody, and then try and get down to those lower levels if you can, recognizing it will be a challenge for some patients. And I think that's the main difference. I mean, the rest of it, triple combination therapy, our approach to lifestyle interventions, everything else we say in Europe and the United States is pretty similar. But I think in Sri Lanka, like most health economies in the world, the priority should be to treat those at highest risk and not medicalize the worried well. I think choosing a blood pressure threshold of 140 to think about giving drug therapy and try and get the whole Sri Lankan population below 140 will probably have a bigger impact than anything else than focusing on worried well individuals who want to, tinker with their treatment.
I have a few questions, if I may chime in here, Brian, because we were just talking about the worried well. I have a few patients who measure their blood pressure, so many times per day and get completely worried if they have a reading that is a little bit off. And I tell them to, stop measuring your blood pressure all the time. Measure it once per week or whatever. What do you recommend? What is the best way to control it?
We have patients at two ends of that spectrum. We have patients who measure, like you say, completely obsessed and measuring blood pressure all the time.
Yes, obsessed, exactly. That's the word.
You have to try and say, look, put it away. Stop playing with the monitor. Just forget about it. Try and get on with your life. I also have patients at the other end of the spectrum who measure their blood pressure a lot and then come and tell me that all the readings are abnormal, but one of them was good, and maybe we should rely on that one. So patients can have a very interesting interaction with blood pressure monitoring, but by and large, the evidence suggests that if patients monitor their own blood pressure, then they're more likely to get control of their blood pressure because they're taking an interest in it. But, you'll always have the extremes. And I agree with you. I think the only thing you can say to them is stop. Just stop measuring your blood pressure. Forget about it. It's normal. And move on to some other obsession.
How intensively do you advise patients to do salt reduction if they have high blood pressure? Because let's return a little bit to the first topic that we discussed. Do you talk with them about salt reduction? And is there any effect in the individual? Or is it just a population effect?
I talk to them, and maybe Wilco could come in. I talk to them about it, and I say, look, the most important lifestyle things you can do are to reduce your salt intake. So if you're adding salt to food, stop. And did you know we have a list of foods that contain a lot of salt that many people don't realize? For example, bread contains a lot of salt, and many cereals, breakfast cereals that are manufactured, contain a lot of salt. So if they suddenly get very surprised and realize they're probably eating quite a lot of salt. And if they if they cook for themselves and want to add salt, then salt substitutes are helpful, I think, although they have become more expensive, I noted recently. But they are potentially quite helpful. But as Wilco said earlier, we need to get more information out, because I think salt is going to turn out to be one of the most important factors, not just in blood pressure, but in heart failure and many other areas that we've underestimated, because almost all the drugs that work now, SGLT2 inhibitors, NEP inhibitors, they're all diuretics. There's a message there somewhere. They're all offloading sodium. So maybe we should start taking sodium a bit more seriously.
Are there some drugs that individuals use where the salt reduction becomes specifically important? What are the 2 or 3 pieces of advice, Wilco, that you give to your patients about salt and salt reduction?
Well, I think
I do the same as Brian. Just try to recommend, I will recommend in all hypertensive patients to reduce their salt. And the problem, at least in the Western world, is that the most of the salt is in the food that is already pre-processed. That's what they buy in the supermarkets. So, of course, you should try to reduce the salt that you add to the diet, but the most of the salt is in the food already. And then your question on does it help in the individual? Well, you have the issue like salt sensitivity, and some people reducing just 1 or 2 grams may be very beneficial to lower the blood pressure. And before,
sorry, Wilco.
Sorry.
I'm going to say it also potentiates the effect of RAS blockade. So we know
exactly. Yeah, and that's one of the other items I would like to explain to the patients, just to inform them that by reducing their salt, their current medication becomes more effective. So we do not need to increase the blood pressure medication, but the potential effect of especially RAS blockers increase as patients reduce their salt, and that's what people like because they don't want to have more medication. So just by reducing salt, their current medication may not be increased.
That's a great point that you're making. Thanks a lot. So now we've been taking the discussion out of the lecture room in Sri Lanka for such a long time. I'm sure it's now good to return to the many questions I'm sure you have in the panel and in the audience.
Just one question about adapting the recommendation to the resource-poor setting, where the recommendation has moved towards the out-of-office blood pressure measurement, but here we have a population who don't have a pressure machine at home and they're not good at using it either. So what about the applicability of using unattended office blood pressure reading to our patients?
I think we have a real issue with the ambulatory blood pressure monitoring because we have very few machines in Sri Lanka, and in the state sector we make them stay in the ward to do the ambulatory blood pressure monitoring, which makes the whole concept of measuring in the natural environment lost when we do that. And most patients, as you said, can't afford for a home blood pressure monitoring, and most of the blood pressure monitoring that we use may not be validated. So that is a second important point. And the way they do it, whether they do it twice a day at the correct time, in the correct way, is another thing. So we have to spend enough time in explaining the patients exactly how to do that if we have to get good home blood pressure monitoring readings. That also, I think, in our clinical context, when we have a short consultation, it's going to be very difficult. Office blood pressure measurement, but without people attending to it, unattended, is a good option. But again, there should be someone, an assistant or someone to do that. That may be the way forward. But I think in a resource-poor setting, home blood pressure monitoring will take over the office and the ambulatory blood pressure monitoring.
I have a question from the panel in general. It's just to carry on from the conversation regarding patients sometimes obsessively monitoring their blood pressure at home and having different types of readings. I have seen in my practice as well that there are patients who come and tell us that, when their blood pressure is high, they double up on their dose of antihypertensive, and when their blood pressure is low, they don't take their tablet at all, etc., etc. So almost customizing their antihypertensives at home. So my question for the panel, is that going to be the new normal as far as treating hypertension is concerned, where patients customize their tablets or antihypertensives to take it when it's necessary and don't take it when it's unnecessary, I guess?
I don't think there are instances where we can actually ask patients to adjust their drugs. For example, in heart failure, I think it is recommended that we ask them to adjust their diuretic dose depending on their weight and the fluid status. But hypertension, I don't think there is a place for patient self-adjustment of drug doses. That is not recommended. I think we have to strongly advise them to write the blood pressure readings and come back to us and for us to change and adjust the drugs. That's what's recommended.
Yeah, thank you very much. I think the time is over. I think it's a time to wind up. And let me thank the Professor Achan Bach back from EAC Leadership as well as EAC Department of EAC Global Affairs for arranging this symposium. And all the speakers, 4 speakers from the EAC as well as SLCC, they did an excellent job. And also all the panelists, let me thank all of them. And also the audience that join us virtually as well as physically, who actively participate in this event. And we look forward for similar symposia in future with close collaboration with the European Society of Cardiology. So Professor Achan Bach, thank you very much. Please convey our regards to your team.
From my side, for everybody in Sri Lanka, and of course to Brian and Wilco for your contributions. Thanks a lot. It has been a great session. Congratulations on it to everyone.
Thank you.
Take care.
Bye. Take
Bye-bye.
care. Bye.
Thank you. Bye.